Welcome back to Brain Trash. This is the podcast where we talk about all of the complicated stuff happening between your brain, your body, your hormones, your life in a way that makes sense to you. My name is Maria Ngala, and this is...
I'm Tabitha.
We are psychiatric nurse practitioners, and we're your hosts today. We are talking about something this week and the past couple weeks that a lot of other people are not talking about in our clinical field. We are talking about hormones and how these interact with the brain. This is a massive gap in psychiatry, and this is something we really want to cover to help kind of bridge the gap here. So today's episode, we're going to talk a little bit about birth control, how this affects medications, how this affects mood, hormone replacement therapy, especially for trans individuals, hysterectomies, perimenopause, menopause, all of the things that, again, not enough people are talking about. So tune in. We're ready for today. Tabitha, tell me a little bit about birth control. What do we got for our knowledge over here?
So I think a lot of people who have taken birth control in the past kind of know, like, either their body does well with it or, oh, fuck, no, I'm not taking that. I've always am a miserable human when I take it, right? And I think it kind of is a vague topic for most people in terms of like what that actually means, right? Because birth control is not necessarily always given for controlling birth. It sometimes is also given to supplement hormones. It's also given to help with really heavy periods or PMS or PMDD or things like that. And so there's lots of different reasons why people end up on these, and there's lots of different types. So a lot of times people who feel very dysregulated with birth control are talking more so about systemic oral contraceptives. So these are things that have either just progesterone or estrogen and progesterone in some forms. And they're the ones that you take. And then there's the placebo days and all of that, right? So what's happening when you take these is you take them and then they are systemically throughout your whole body because you've ingested them. Now they go through the first pass in your liver and they're having to be metabolized in a very specific way. There are also lots of other types though. More, I guess, recently would be things more like the IUD, which is all of those are either non-hormonal or progesterone only. So it's a device that gets put in through your cervix up into your uterus and then has little arms that go out towards your fallopian tubes. Not a pleasant experience typically to get it inserted. However, it is only localized hormones. And so in this way, it can affect people a little bit less. Now, this isn't a blanket statement for everybody, certainly not medical advice on what you should or shouldn't do with your body, but can give people better results if they do find they get more dysregulated with the oral contraceptives. So that's something that you would talk with your OBGYN about, you know, what's right for you if you are a person that's looking for something like that. And then there's also like patches. There's, I want to say it's like NuvaRing or whatever. There's different types of like wearable or insertable or like Nexplanon, the implant one. It just goes in your arm like a little 5G tracking device. But the one thing that is very similar across the board is you've kind of got three different types, right? You've got non-hormonal, you've got progesterone only, and then you've got the combination, which is progesterone and estrogen. And these are all going to work and release and all of that a little bit differently depending on what type it is. But this is something to look at if you are a human that has problematic cycles, who has big shifts in mood or mental health symptoms or things like that. It's possibly something that could help. It's also possibly something that could make it worse. And that's the worst part, is we won't really know unless we try.
And it's one of those things too, where like, unless you really understand your cycle and understand which hormones you are more sensitive to, because we don't know everyone's baseline dopamine, serotonin, norepinephrine. Some people have lower amounts of these and are more sensitive to different hormones, right? You might do really well with an estrogen and be like, yeah, I finally feel good. Or you might feel really anxious when you have those estrogen fluxes. Having the correct ratio in a birth control, really, really important. Or if you're like, I'm just fucked with all the hormones and I have executive dysfunction and I can't remember to take all of these pills, and now my moods are even more fucked up because I take it erratically, right? Copper IUD is non-hormonal. That's something that's in for 10 years. It's a really great option. Hormonal IUD, as you said, like something a little bit more localized. You don't have to remember it. Nexplanon's another option that's kind of, I think it's progesterone only, and it doesn't worsen depression as significantly as like some of the oral ones might.
Yeah. The biggest problems that I see with these, like in clinical practice, is it takes a while to adjust. And so in the initial phases, I see a lot of people feeling super dysregulated. And that in and of itself can cause people to like jump ship and be like, oh, fuck this, it was the wrong choice. So making sure that as you go into it, you have the ability to regulate yourself, that you have some distress tolerance, some coping skills, those types of things built up, so that if you do feel a little dysregulated in that adjustment phase in the first few months, you're not spiraling and having crisis times and that kind of stuff. And then also, if we're doing something like an IUD that has hormones in it, or even some OBs, like for example, when women with PCOS, sometimes they'll have them take the oral contraceptives but skip the placebos for a few months. If we're not having a cycle, right, if it stops your period, so a lot of people have either super light spotting on IUDs, no period at all. Some people keep their period. It's kind of, again, different for everybody. But if you're not having a period, it can be harder to correlate these things to your cycle, even though your ovaries are still going through a cycle, right? So you are still going to have some fluctuation. For most people, specifically, like if we talk about progesterone only IUD, right? This is stopping your uterus from building and shedding, aligning every month, right? But some of the other reactions that happen with that do dampen the effects of the ovaries. So it's not necessarily doing the exact same thing, but for most people, it will kind of flatten out the curve of estrogen fluctuation. So instead of these big peaks in the follicular phase and big depletion in the luteal phase, you're still going to have a little bit of that, but it might not feel as aggressive and distressing. However, you could be a person that it does not affect that at all, and you still have those big ups and downs, and you may still need like luteal dosing of something, but you're not going to know it's your luteal phase if you're not bleeding, unless you track it.
What about ADHD? What do we got for ADHD brains?
Yeah, same with ADHD brains. That piece can make it really hard if you are trying to kind of plan for more executive functioning tasks in your more productive phases. So end of menstruation into follicular makes it harder to understand where that is. A lot of times I'll have people do luteal dosing of a stimulant before I'll be like, here's a new medication for your PMDD. So it can make it harder to time the luteal dosing of that. And you have to go more based on symptoms. So knowing yourself and knowing your symptoms is the biggest priority when we're looking at that. With ADHD though, like you said, it's hard to remember to take a pill every day. This is why a lot of times there's higher rates of like teenage pregnancy in adolescents, because they can't remember to take birth control, or maybe they've got more of those periods of time where they're having impulsivity or risky behaviors, right? So there's a lot that can go wrong with the pills, specifically with ADHD, just based on forgetfulness and inattentiveness and impulsivity. And then when we're looking at anything that includes progesterone, again, when we talked about in the first episode, when progesterone is higher, we may feel a little bit more inhibited in our ability to focus, concentrate, get motivated. It may make us more inattentive. And so this might mean, hey, it's not a great idea. It also might just mean, hey, we might need to boost up the stimulant dosage a little bit, or whatever med you're on. We might need to give you a little bit of more support there. Or we might just need to create a better non-medication systems in your life that help you if you're somebody that's not super distressed by the amount of inattention that it brings you. But again, if our progesterone is a little bit higher at baseline, it's very possible that we can experience some worsening of inattentive type ADHD symptoms.
And that's one of the things too, where providers who do birth control need to look at, like, do we need to add in like a combined type with like a higher estrogen ratio to make sure the dopamine is not going to be completely messed up? Or like, should we be considering an IUD because this could mess with the dopamine of this person and it could mess with the efficacy of the stimulants? Or just like working alongside the psych provider, right? But like making sure that the patient is informed is the biggest thing, because a lot of people will just go and start birth control, then they come back to us and they're like, I don't know, my stimulant doesn't work. Anything new happen? Yeah, I started birth control recently. Well, what kind, right? But they've never been informed. So there's no technical interactions, but hormonally there are interactions, and those need to be considered.
Yeah. And this is where we have this huge gap, gray area where a lot of people fall into the deep, dark depths, is between the knowledge of their provider that's providing hormones or birth control and their psych provider, right? Because there's this middle ground that everybody's like, oh, that's not really my thing, right? I can't prescribe hormones. And then the people who can prescribe hormones are like, it won't affect that. There's no interactions.
Like the naturopaths who do that, and then they come back to us and they're on like progesterone, and it's like, okay, but now nothing's working, and now I feel worse, and it's like, but did they talk to you about the interactions? There's no interactions. Like, oh my God, I can't.
Yeah.
Worst birth control, FYI, Depo shot. If you are ADHD, depression, like predisposed or have any of those things, Depo is probably not for you unless like proven otherwise. Nexplanon, like potentially not great. And then like oral contraceptives is kind of like hit and miss. But Depo's got like a higher rate of depression associated with a higher rate of like ADHD problems. Patches might not be great for people who have sensory issues with autism, but could be better for like the ADHD mood wise. Like it really varies on, I guess, your sensitivity to hormones individually.
Well, and this ropes right back into what think I've probably said across all of this shit is this is the reason why at some point in researching these things and trying to figure out what's best for who, eventually they give up because you cannot control for all of these variables. Everybody is so different. And so when we know, hey, I'm about to do something to my body, I'm going to fuck around and find out, and it could make this better, it could make this worse, we've got to go into it. And again, this is, side note, caveat, this is fucking bullshit. That as a person who already struggles with a bunch of shit that's not researched, you now have to take on this extra responsibility to essentially be the only person watching out for you. Mm-hmm. But anyways, I digress. You need to go into it knowing, hey, I've got to have these skills and these tools to help me with any type of emotional dysregulation or worsening executive functioning. And when you add in on top of this, that a lot of times people who are seeking out this type of support are going to be adolescents going through their first, years of periods, pregnancy and childbirth age, mothers, perimenopause and menopause. These people are already in some of the worst times in their life, and now they're having to take on this extra responsibility. So I get that it's not just a simple fix, but it's also going to have the highest yield and results versus going to a provider who's likely going to gaslight you or give you something that's going to make it worse.
Accurate. And then moving on over to hormone replacement therapy. So let's start with testosterone. What do we got for testosterone? That's a hormone we haven't even touched yet.
Yeah. A few things with testosterone. I mean, obviously, if your testosterone levels are too high, you might be raging the fuck out and wondering why you got mad at another driver and kicked the windshield out of your car. So if shit like that is happening, it might be a good idea to I don't know, go talk to your doctor prescribing the hormone and ask them to test your levels. If you're being put on some, specifically testosterone, my biggest gripe is a lot of times, especially these hormone clinics, the pop-up places that are a big money grab, they'll be like, you get testosterone and you get testosterone, and they're just throwing that shit around, right? Oh, it's low here, this will be great. And people initially do really well because it's great for libido, energy, all of that, right? I can work out harder, I feel better, all of that. At the end of the day, if we're not retesting those levels and making sure that they're in some type of therapeutic range, I've seen people go back for testosterone testing after I've been like, hey, you really need to go talk to your provider because this is not a mood thing. This is your shit is
fucked.
I've seen it where the test came back so high that the machine couldn't even read it. And nobody had checked this person's testosterone in 6 months after first initiating testosterone. So there's a lot of times where it shouldn't be the patient's responsibility to say, hey, we need to check this level. There should be more follow-up happening with these things. So if you're with a provider, if you're a patient listening to this and you're with a provider who's not testing these things and not checking in on you, most of the time, the best HRT providers in my area are having people get labs at least every 3 months. And that is across the board with all of the reputable places that are actually doing HRT. And so, again, I don't know. Again, I'm not a hormone provider. I don't prescribe them. So there may be different guidelines out there, but that's kind of what I see with the people that are having better outcomes with HRT is these providers who are staying on top of tracking this for them to make sure that they're actually therapeutic and it's not just a complete fucking shit show.
Yeah, I mean, we're really seeing kind of the mood ends because we're getting more of that, right? So things testosterone does, just as an FYI, increases dopamine. So focus going to be improved, motivation, typically, as you said, libido going to be improved, norepinephrine, more energy, right? But I mean, too much of these things, we could have high anxiety, we could be jittery, we could be agitated. It usually kind of decreases serotonin. It renders SSRIs essentially to be ineffective. So people who are on this might do better with an SNRI, might do better with bupropion for depression, but we might see the SSRI start pooping out once we're on testosterone. And then looking at like antipsychotics, I guess antipsychotics and stimulants. So testosterone makes you blow through your meds faster. You're going to metabolize super fast. So if you had Vyvanse working 10 hours and you started testosterone, that could be working now 7 hours. Or like you had Ritalin working for like 4 hours for an IR, it might work an hour now. That is something that is not like, oh, they're lying to get more meds. That's literally like, that's what's happening in the body. It is making the clearance go a lot faster. Stimulants might need to be moved to an XR. There might need to be more dosing. Like that's really common. We might see cycling in bipolar folks, and like the antipsychotics might have to be adjusted to a few times a day, adjusted more at night to help it be a little bit more sedating. And then one of the other things that is really common with this too is that autistic folks, and there's a high prevalence of trans autistic folks who end up on testosterone, would have an increase in sensory issues because of this. So we're looking at like more auditory sensitivities, like I don't want to be touched, I'm getting like tactile, I'm getting overwhelmed. Like more sensory overwhelm is very, very common being on testosterone too.
Well, and on the flip side too, when you've got people that are on blockers, right, you might see the opposite where, you know, if somebody's put on spironolactone for either gender affirming care or PCOS or even for blood pressure, and they don't realize that it's a testosterone blocker as well, or just lowering androgens. These are things that, again, are not commonly well educated about by the prescribers who are actually prescribing these things, unless you are at, like I said, one of these reputable places that really does take the time to do that. So you may have the opposite where now all of a sudden you can't sleep because your stimulant is lasting forever and you're not blowing through it, you know?
Yep, exactly. And it's like the dosing might need to go down. SSRI, same thing, right? Like we're looking at the opposite effect. So like the SSRI dose might need to go down once we start HRT and like spironolactone. Like that is something we could look at. Like these drugs might feel more potent all of a sudden and like they're just doing too much. Like insomnia is happening, nausea is happening. Like we're just getting more of the side effects from that. They're going to stay in the body longer. Yeah.
And goes to show why like having a 5-minute appointment with your patient is not doing them any good, because what this is going to do if we're not taking the time to ask about new meds, hey, what about from your other doctors? Do you see any new specialists? And not talking about things like HRT or asking about, you know, gender identity and talking to them about, hey, how do we prepare you for this if you are planning to start HRT or anything like that? Or even if it's completely unrelated and it's just medications that do impact hormones. If we don't take the time to do that, now all of a sudden, if somebody comes to us and all we know of is, hey, I'm on this stimulant, but all of a sudden I'm not sleeping and it's been about a week. Mm-hmm. Again, buzzwords. What are you going to think? Oh, they're having a manic episode and I need to stop the stimulant. This shit is going to make them so much worse.
Correct. And another thing to consider too, when you have somebody who's on like spironolactone and estrogen, like this is imperative to look at prolactin more commonly if you're looking at antipsychotics. Like prolactin elevations are incredibly more common once you have that combination in. So looking to like moving over to something that's more neutral, i.e. Abilify, because that's really the best one, is pretty much, that's a huge thing. I know like lithium's pretty much unchanged with like all of these HRT things, and Depakote, those are like the two biggies, but like everything else can be very much shifted. Lamictal definitely gets shifted through the hormone stuff. That needs to get adjusted. SSRIs, SNRIs, stimulants, all of those need to get adjusted once we look at HRT.
Yeah.
All right. And then moving on over to perimenopause.
Yeah. Yeah. Well, and I think this is something that's like very much, kind of like how there was like TikTok trends with autism and ADHD and all that, right? Now, all of these people are going, wait a minute, those things sound really familiar to me. And I'm also in that range, right? Does this mean that I'm going through something like perimenopause? So I have a lot of patients who are presenting, asking about these things. Again, because I'm not a hormone prescriber, best I can do is educate people what I know and then have them talk to their other providers, which their other providers are likely going to gaslight them and tell them that it's not a thing and they're too young, because that's what they always do. Anyways, when we look at the hormone shifts that are happening in perimenopause, again, just like we have with all of the other things, we've got this regular cycle that's happening throughout our whole life for like 40 years. And then all of a sudden comes a day where things start to change. And we're not in menopause yet because we're still having periods. We're still cycling. However, each of those cycles looks vastly different. We may or may not have a period. There may be a lot of different timing on each cycle. You might have one, 2 weeks apart and then not have one again for 3 months. And then that could change and go back to your regular cycle for a little while and then be fucked again. And so this time frame, I think for most humans with mental health disorders who cycle, this timing, the perimenopause, is commonly much more dysregulating and distressing than actual menopause itself. Because in menopause, at that point, our ovaries have been like, okay, never mind, I give up. And they're just at a solidly shit level all the time. So that's predictable. Whereas when it's like, I might be cycling or I might be pretending I'm in menopause for a minute and then all over the place. This is probably one of the highest, most gaslit populations I see, and it's a huge portion of people. And it can start as early as like 35 in some people. Again, it's not always like a, hey, at this age, if you have these symptoms, that means this, but it can start a lot earlier for people, and especially if you have any other factors impacting that. And most of what we have in terms of research has been pretty shit per usual, because it's not a white dude's body.
Accurate.
But I really think that we need more providers to educate themselves about what this looks like so that they can be impactful on the hormone prescriber side, because there's actually even newer research that just came out, I think, over the past month or two about how we've been pretty wrong about estrogen replacement specifically. There is a lot of times where people will not be placed on estrogen because it's like the stigmatized view is, oh, this can cause breast cancer and blood clots and all of these things. But what we know about it currently is that it actually can be really protective against cardiac stuff, bone fractures, mental health, cognition, all of those things. And so the shitty part is getting this into practice takes a while. I want to say way back in the day when I was still like in the beginning of school, I remember them saying something like it takes 17 years to get research into practice or something, which is fucking insane. We don't have time for that. Like, people are suffering, right? And so really being on top of your providers about, even at bringing in studies, educating them about it if it's something that they are not listening to you on, or finding other providers. But again, I know that that's next to impossible because there are very few who do actually know these things and specialize in these things in a way that's actually up to date. And so getting to a place where you can identify what's happening and share that in a language that makes sense, or in a way that's like, hey, I feel like shit and I need somebody to do something about this, and starting to advocate to get what you need.
So hallmark signs of perimenopause, just to like help people, like, could this be it? Because I mean, like, as you said, it could be as early as 35. It could be like really into your early 30s for a lot of people. If you have a history of like chronic stress, trauma, ADHD, neurodivergence, like, I think if you're a smoker, there's just like a lot of factors that kind of draw you to be a lot earlier into that.
Yeah.
Period changes are your number one thing. So if you have like a cycle change, all of a sudden, like, you're noticing it's shorter, it's longer, there's skip periods, like heavier, longer, just like shifts in that, like, that are not normal for you for the first time, that's like your number one sign. Early morning awakening. So when you're looking at like 3 to 5 a.m. and you're waking up that early, oftentimes that means like your estrogen has crashed. Therefore, like your norepinephrine has a shift, and then you wake up at that time. Night sweats, that's like a big thing. Hot flashes, night sweats are usually the first thing to show up. Worsening, like mood swings that don't make sense, irritability, crying, rage. I don't feel like myself, something's wrong. And it's like, it's very much a fluctuating thing. It could be by hour, right? Like, it's not necessarily even weeks or days. Sleep problems, so like lighter sleep, I'm waking up more frequently. I can't fall asleep, I'm waking up like sweaty, I'm waking up really anxious. So waking up at 3 a.m. anxious, that's a big sign of a hormone thing.
This is actually what I see most commonly people come to me first with, is that sleep change. And I would say 99.9% of the time, what do? They go to their provider. Their provider says, oh, sure, we'll say that you're in perimenopause or whatever. After they get hounded enough by the patient, they give them 100 to 200 milligrams of progesterone every single night. They're like, I'm sleeping great. and I feel like a fucking idiot and I can't get anything done.
Yes, let me just have like extreme brain fog. And that's like brain fog. That's like even worse for ADHD folks, right? Like that would be completely exacerbated. There could be like joint muscle pain. There could be like libido changes, whether it's like increase or a decrease. If you have low estrogen, you'd be looking at like more vaginal dryness, atrophy of those areas, which is kind of wild when you start looking at that. But those are pretty much your big signs that perimenopause might be kind of in here. Either as the patient or as the provider, imperative to be considering this with people in their 30s and 40s.
This is also something where you may have a woman who doesn't have ADHD, but she's coming to you and saying, hey, I've been on this SSRI my whole life and it's always managed my depression, but I feel so depressed. If you don't ask the right questions, you're not going to learn that, oh, that depression is actually like the cognitive dulling or the forgetfulness or the like, I can't get anything done, so I feel like a piece of shit, or I'm not a good enough mom, or whatever, right? This doesn't mean that we necessarily have to make changes, but if you increase that SSRI, it's likely that's going to get worse, right? This might be a situation where even if somebody's always done great on, sertraline, you might still want to start something like a Wellbutrin instead, or an SNRI. This is a lot of times why you'll get OBs and primary care docs starting women in perimenopause, menopausal ages on like venlafaxine or desvenlafaxine. These are ones that have that norepinephrine component and make people feel better because they have more energy, but we're still not touching on that dopamine component with that estrogen depletion that's happening.
Yeah. And like one of the other things to just bear in mind too for autistic folks, sensory issues worsen during this time, just like anything else. So, one of the other joys of being autistic, migraines, light sensitivity, more noise sensitivity, all of the things heighten up. So even if you have a parent and you are autistic and you're like, I don't know, it's genetic, right? Like my mom or my dad must have it. You should be looking at your parents as they're in menopause being like, well, shit, it's a lot worse. You're covering your ears now. So talk to us about like a little bit about the shifts that happen, because like there's early perimenopause, there's late, we move into menopause. What's that look like?
Yeah. Well, and again, just like with everything else I've said, it's different for everybody. It might be a very short period of time that's not distressing and you're like, oh shit, some changes are happening. And then you go a year without a period and you're like, oh, here I am in menopause. However, most people, it's going to be a bit of a shit show for a hot minute. And so this is different for everyone. Years and years. It could be 10 years. It could be 5 years in perimenopause. And it could be something where you don't really have a whole lot of diversion from your norm. It's just kind of here and there. Or it could be every single cycle is different for that entire time frame, which is fucking insane. Right? And so this is going to be something that's more so personalized to each person and kind of how they're experiencing it. Typically later in perimenopause, when it's a little bit more obvious and we are having pretty consistent changes with these symptoms that you've discussed, that's going to be more like 1 to 3 years. And this can go like 2 months between periods, or they're just like a lot more irregular than they are regular. And then early menopause, we're looking at like 12 months without having a period. And it's so funny because a lot of people actually will experience this, but people don't educate their patients on this, that like I have so many women who go 11 months and then they have a period, and now you have to start that 12 months again before you get to count as being in menopause or postmenopausal, right? So there has to be a full length of, it used to be a different length of time. It's like, it's always changing because again, we are just now barely learning about women's bodies and how they function and the differences between each person. So again, that number is not necessarily like you must, but that is how they're going to clinically define you as being either perimenopausal, early menopause, or postmenopausal. And then from there on, after you stop having periods, that is late menopause. That's the rest of your life. And what happens is your ovaries are no longer cycling. And so in this time frame, if we don't have hormone replacement with estrogen, progesterone, whatever it is that your body has landed on as its new baseline, if we don't have hormone replacement, you can expect to see a lot of like just low energy, forgetfulness, problems with processing, low libido, vaginal dryness, that kind of stuff. So increased urination is another one that I hear a lot with postmenopausal women. So this is when, if we land at this new baseline, we're postmenopausal and things still really suck, I would always recommend that these people find a reputable provider to help them kind of take a look at where are my hormones at now and what might be helpful for me.
Correct. And then looking for our end of like, how do we adjust medications during this time? So we learned the past several episodes about like, how does estrogen affect medication? How does it affect our moods? So we know that ADHD worsens when estrogen dips. We know menopause, we're pretty much fucked now on estrogen. So ADHD meds, probably going to be needing a super fucking high dose. So there are a lot of people who are like, oh my God, I could never give like more than 10 of Vyvanse to somebody who's like 65, a woman. Oh my God, they might have a heart attack. And it's like, well, that's really not going to be fucking effective at all because there's no estrogen there, right? So they're going to need naturally a higher dose. They might need more doses of it. And then looking at like, you know, what's the crash going to look like when they come down from that? How do we prevent that from happening? Do we need like a Wellbutrin to keep that dopamine like from having a massive crash every time that stimulant comes down? Or like in perimenopause, are they having, you know, if they're already on a stimulant, like surges of anxiety? Do we need to reduce that dose and have like more, flexible dosing where like maybe there's a lower dose and they can take more some days and less another day? That doesn't mean we're allowing them to abuse it. That means we're allowing them to know their bodies and to understand how much they need to take when they need to take it.
It's always funny to me because I'll have students with me sometimes, or, you know, even just talking in clinical staffings or things like that, where I will mention that this is something I do commonly, and it is evidence-based. It's based on research. I have so many very responsible patients who do their stimulant this way in perimenopause, or they'll do luteal dosing, which some research shows luteal dosing as stimulant is superior to starting like luteal dosing of an SSRI if the core of those low mood symptoms or anxiety symptoms is related to ADHD or executive functioning, right? So that can be 20 to 30% higher dose of a stimulant in the luteal phase of the cycle. I'm not sitting around saying, well, what phase of your cycle are you in today, right? Mm-hmm. What I'm doing is I'm giving my patients agency over how they treat their symptoms that day in a way that's still responsible on dosing, but gives them the ability to monitor themselves because, again, they are the only person that's going to understand their own body because there's so much variability, right? So I'll have some people who just take an XR, and then when they're in their luteal phase or extended release or whatever it is for med, and then in their luteal phase, they'll have an immediate release booster that they can utilize in whatever time frame we talk about, right? So sometimes that means they might take half of it in the morning with the extended and then half in the afternoon. Sometimes they're just doing the afternoon. But when we look at perimenopause, this isn't something that is predictable like that. They can't say, oh, I'm in my luteal phase. We don't know. We never will. They won't either. Like in your own body, if all bets are off, there's no way to say, oh, well, on this day, I'm going to start my luteal dosing of my stimulant, right? So what I tell them is, here's the symptoms we're looking out for. If you're noticing this, or if you maybe live with a partner, or you have kind of metrics that you use to track, oh, this is how I know it's getting worse. Those are the days where you're going to say, oh, yeah, this. And then you do the luteal dosing or the flexible dosing, I guess is a better way to put it in the perimenopause stage. But, It really is back asswards because when you look at the way that most med providers are trained, and understandably so, because some people will misread that information and say, oh, well, I'm letting somebody abuse their stimulant. However, these are evidence-based uses of stimulants. This is not misuse. This is not, hey, I'm fucking around and finding out and doing whatever I want with it. We have this discussion and we have very clear boundaries on like what that flexibleness looks like, flexibility looks like, flexibleness. And these are some of the most responsible stimulant patients I have because they understand their bodies and their brains really well. They know exactly when and how to change that in a way that works best for them and decreases their symptoms of depression, anxiety. It improves their sleep. It improves all of these things for them clinically. And that benefit is absolutely worth it.
For sure, dude. That's huge. And like, this is kind of the point where like we're taking this point in the podcast to like ungaslight you. Is that a word? Let's ungaslight you. If your provider has been like, no, this can't happen. Like your stimulant was working for 2 weeks. Like it can't be just dipping out and then like working again. Yes, absolutely, dude. Especially if it's menopause. Like this is not in your head. Perimenopause, this is not in your head. If you are neurodivergent and you have some of these things like MCAS or POTS or anything like that, know that these like perimenopause and menopause, estrogen, all of those things also affect these conditions. Norepinephrine is like very involved there. And like you will have more dysfunction during these periods of time too. That is also not in your head. You might be going to cardiologists who are like, no, that can't just happen. You're not just going to have palpitations. Like your EKG is fine, whatever. Like if you have these things underlying, is absolutely fucking, like absolutely a fucking thing. All right, any last things to add here? What people can do, anything like that? This will conclude our hormone series.
Oh God, there's so many things I could say, but in reality, know your body and where you're at and what it's doing and how that impacts you, right? Figure out what is the most distressing and what could be causing this. Keep track of it in whatever way is possible for you. It doesn't have to be anything super organized or structured, but something that works for you. And advocating for yourself. Lots of great resources in terms of like AI or, you know, other humans on the internet or things like that, where you can gather information, structure it in a way that helps you to, even if you need to go to your appointment and read off of a list of questions that ChatGPT came up with based on the information you gave it, like saying, no, I want to talk about these things. And if you don't know this, refer me to a provider who does, because I'm experiencing this and it's real. And that way you have the ability to not even necessarily make any of this 100% better, because again, the research blows. We have nothing definitive. Nothing, right? Like, I shouldn't say nothing. There are some definitive concepts and theoretical frameworks and all of these things, but it is still very much emerging research, emerging practice areas. And so finding a way to disengage yourself from the shame that is connected to that is the most important thing you can do for yourself. The amount of people I have who are bipolar, and then when we really, really get to it and they start tracking, we realize, oh, all of these symptoms that looked like that are actually only happening in the luteal phase, or we're only getting that risk-taking behavior at a specific time in the cycle. That's not bipolar. That is a hormone change that is trackable and physiologically impacting you. And so looking at, what do we do about this? How do we change the course of your treatment in a way that stops calling you the one that's like crazy and has it all in your head, and starts looking at the actual things happening inside of your body specifically?
Yeah, dude. So, that being said, if you cannot find an affirming or a knowledgeable clinician, because here we are being like, go find one. In many states, there really like are not. And finding one is like, it's hard. And how booked out are you, my friend?
I'm not.
You're not even
not taking new patients out.
That's what I'm saying. And like, there we go.
And because to me, this is like bare minimum, right? That I should know these things to advocate for my patients. To me, this is like across the board should be a thing that just is like, oh yeah, okay, we should all, but it's just not. There's not a lot of people who do this. Now, granted, that doesn't mean there's not any others. They are certainly out there. I've seen plenty of different, discussions and clinical things and all this stuff. There are people who do give a shit about this. And so even if that means you've got to try out a few different providers until you find one who actually takes you seriously, you are allowed to never call a provider back. You are allowed to cancel your appointment and go somewhere else. You are allowed to do these things as a patient. You can advocate for yourself in all of those ways. I know it's a shit show to like get reestablished places, but figuring out where you feel the most heard and seen so that you get the most effective care you can is really important. And that's going to be hard. And again, it's absolute bullshit that it's as hard as it is. It shouldn't be.
You can refer your providers over to our page, though. So we'll have some resources on this that you guys can check out, paperflowerinstitute.com. We'll have a whole host of some free shit to take out, and you can print it out and give it to your provider and be like, look, I have all this evidence-based shit. Or like tell them to listen to this podcast. And again, they'll be like, this is not professional. This is a fucking joke. But you know what? We're CEU approved for our, for our stuff for them, for our training. So, got nothing to say for that. Thanks for tuning in. We'll have some more episodes coming up on neurodivergence, and we'll be a little bit more consistent. I guess this is season 3 now. But yeah, like, share, send this to your provider, send this to your friends, to your menopausal, postmenopausal mother, whoever needs to hear it. And thanks for tuning in, y'all.
With you in solidarity of the hormone train.
Solidarity. We're in our 30s too.